Welcome to Working Smarter, Concise Compliance Conversations featuring Wendy Rubis, sponsored by VillageMD, primary care physicians, practice medicine the way you've always wanted, data, resources, and clinical decision support to care for your patients inside and outside the exam room.
Hi, welcome to Working Smarter. I'm Wendy Rubis, General Counsel of VillageMD. My pleasure and honor to be here today with Megan Harkins, Assistant General Counsel here at VillageMD. Megan, welcome.
Thanks for having me back.
It's so great to be recording this. We've been talking about doing this, I think, for a number of years, right?
For sure. At least a couple, at least since I've been here.
And what we're talking about today is what we call freebies, waivers, and copays for patients. And there's a lot of rules and they're not intuitive. So we're going to kind of walk folks through them today.
Because if a patient needs services or they need certain medical supplies, why would that be then an issue?
That's the question we get asked a lot. And I like to say, this is why we can't have nice things. So there are cases out there that, are high profile at different times where freebies, waivers, and copays get abused. And so, for example, there's cases where an emergency room starts sweeping up homeless patients to bring them in and be able to provide, billing and revenue for the emergency room. There's cases of unscrupulous practitioners who went around with medivans and just picked up people and everybody got podiatry that day, that kind of thing. And so there are reasons based on these examples that you can understand. And first of all, there's a concern about overutilization. The second thing is, as we all know, the cost of healthcare has gone up. One remedy that payers have imposed to try to manage the cost of healthcare is to shift some costs to the patient so that every time a patient goes to use a healthcare service, they have to pay a little something. And the idea behind that, those copays or deductibles or however they're structured, is that the consumer will have some alignment and incentive to not overutilize. So when you waive those things, the concern is that you've tampered with that benefit design, which was intentionally designed for an overutilization concern. And finally, when you have charges, and we'll talk about this a little bit later, but when you have charges and you waive them or you create a different cost structure for a certain subset of patients, it can cause payers like Medicare or even commercial payers to challenge that they should be subject to those same discounts. It interferes with the usual and customary charge schema. And so this is the reason we have these rules. Although, Megan, I think what we've seen really in the time since you've been here at Village is this landscape is changing fast as value-based care becomes more of a priority for our programs.
It is, absolutely. And I think that's just because of the focus then of where we're trying to I don't want to say steer patients, but where patients are going to get care. And relatedly, there's a lot of reasons why we want to make sure that we're on the right side of this, on the value-based care side, and we're doing it for the right reasons. And that could range from anything from a breach of contract with our commercial payers to exclusion from the federal healthcare programs, which most know if you can't bill for Medicare, Medicaid, Medicare Advantage, it's really hard to have a continued healthcare book of business.
Right. So these are enforced and there are consequences and there's lots of rules. So let's just sort of try to go through. And Megan, I think we would say a modern healthcare law department today, we get these questions a lot, right?
A lot. Almost every other week.
Yeah. So we're going to sort them out today. So the first kind of umbrella question, which is really many, many questions within a question that we get is, hey, Wendy, hey, Megan, can we just waive these copays?
Great question. Short answer is that it's complicated. If you're continuously just waiving patient copays, you probably should call legal counsel to make sure that they've signed off on it and that we're sticking within specific safeguards. And there are some exceptions to this, which we'll talk about in a couple of slides.
Yeah. So the answer is probably not, but maybe, which is the kind of answer we love as lawyers. Okay, so let's go into some of these other exceptions.
So Wendy, can we give patients a discount if they provide payment at the time of service?
The first thing I would say, just as a caveat, state law varies. So let me just say that you have to check your state law. But absent that, the short answer is you can probably do this, yes. However, it's not a carte blanche to give any discount that you want. It has to be reasonably related to the savings from the prompt payment. So what that means is the assumption is that if somebody's paying you up front at the time of service, you don't spend money on an invoice. You're not spending money on collection. All of those back office things that have to happen, you don't have to do. So the recommendation would be do a calculation. Doesn't have to be exact, but at least a good faith calculation of what that savings is, and the discount can reflect that.
And then maybe loop in legal counsel, right, Wendy? So make sure that we've got some type
Yeah.
of record on file.
Well, it's a good time if you're at VillageMD because obviously we're here to help. But if you're not, then yeah, you should work with your legal counsel to document that for sure. Okay, Megan, here's one for you. What if the patient has financial need? Do you have to collect no matter what?
Yeah, Wendy, that's a great question, especially when we're talking about making sure folks from any socioeconomic background has access to care. And so the short answer is yes. There are several factors that we would need to consider. And typically this isn't something too that you would advertise. Rather, the best practice, I would say, is to have a policy in place that'll help guide the organization then through this process and certain forms that, discreetly you ask the patient to fill out. This doesn't mean that you need to be asking for copies of, their tax statements. It's a good faith determination. And so assuming that the patients are truly in financial need, we as a healthcare organization don't want to turn away a patient who probably needs the care.
So this is a funny rule, in some ways archaic now, and you can see if you're watching along, there is a specific prohibition on advertisement. That harkens back to those abuses I mentioned at the beginning, where somebody would have an ad in the paper, hey, free ride and come on down and we won't collect your copay, or if you have financial need, like, let me just gin up a bunch of Medicare billing. So that's the reason for that non-advertisement. That's becoming outdated somewhat today as we look at health equity, as we look at in a value-based world, but it still is there. And then the other thing that's kind of evolving our understanding is there used to be this thing about, well, you can't just take their word for it, okay? You have to actually do some determination. And that, got really carried away in a lot of cases and put people really through this very invasive thing. So there's a movement to sort of change that and say, well, if you're on another public program, we're going to assume that they did the checking, or there's other ways that we can sort of get to that good faith determination without doing a invasive and expensive time consuming review. But the point is, it's not just offered up as a pretext or a ruse to waive copays for everybody.
So Wendy, another question that we get often is whether we can offer patients a self-pay discount and how that then is also different from that prompt pay discount we talked about already.
This is a hard one. There's a complex web of laws and rules here, state and federal. We used to just go, no, you can't. And then we felt smart and we sort of moved on. Then we had changes in federal law, really through the Affordable Care Act and other changes that required us, hospitals at least, to give a discount for self-pay patients and calculate it a certain way. And so the short answer is, yes, you can probably work something out. The risk that you have to manage is the usual and customary charge rule, so that if every self-pay patient gets a 10% discount, that jeopardizes your ability to say you have a usual and customary charge that's going to Medicare. And you can see some high profile cases even recently with some pharmacy matters and some other places where they started doing this. So the bottom line here is just, this is a complicated one. Just please call Megan Harkins for the answer.
Thanks for the volunteering.
You're welcome. Megan, this is an age-old practice. We know that physicians tend to give professional courtesy to other physicians or healthcare providers. What is the rule on that?
Yeah, great question, Wendy. And like you said, this is sort of an age-old practice. And so short answer is yes, but don't get too carried away. The AMA has come out with guidance. Your state medical board may have similar guidance. Essentially, it boils down to, like, if you're going to do it, it's probably wise to have a policy in place that then you follow.
Yeah, and there's sort of a wink wink that goes on. So, but if it becomes a substantial practice, you should probably be careful and get some legal advice.
And so another question for you, Wendy, is whether we can give freebies to patients, like a water bottle or a pen, or even like certain services.
The rules here are changing for the better. There's always been this sort of exception in the safe harbors that allow you to give an inexpensive item. And there's this $75 annual cap. So if you give a water bottle and then a pen and then which has this crazy requirement in some ways that you're going to be able to track that, which is just like really hard to do. Okay. So there's always been this de minimis exception. Megan, I think there's another exception for preventative care. Can you explain that one?
Mhm. Yeah, so I guess with the recent changes with the Stark and anti-kickback rule, there's certain exceptions for preventative care items or services. Now, the list is limited. It's not, again, a carte blanche pass to just give things away to patients. If it's typically reimbursable by Medicare and it's not like a gift card, there might be an exception where we could provide that to patients at free of charge.
So, but this is where we're starting to see some good movement because, I have to say what I sort of come to as a lawyer is when people ask me these questions and I have good clients operating in good faith and they're not spreading around in the neighborhood with the Medivan trying to do, some of the abuses that we talked about, I usually make a decision based on, is it good for the patient's care? And if it is, then we should do the right thing by the patient. That's not exactly been in the rule. And so we're seeing movement now, recently, I want to say maybe the last 2 to 3 years, where we have a new exception that's basically if it helps a patient access medically necessary healthcare services. So this is basically like you can give them a ride. You know, this is where when you draw bright lines, you create absurdity. So we had these abuses with the Medivans, and then we had a problem where like people can't get to the doctor or you can't get them home and you're afraid to do free things, which makes no sense. And so this allows us just to do what's reasonable and good and common sense, which is really welcome in this environment.
Especially, like you said, as we're moving towards value-based care and population health management, these are key items that patients need in order to be on top of their healthcare and to make sure that the providers are also looped in as well. So, if a patient has diabetes and they need a glucose monitor, you as a provider would hate the excuse, well, like the patient can't afford it and can't get it. It's just an absurd barrier to care,
Right,
whereas
right,
giving them that glucose monitor would help them take charge of their healthcare and better manage it.
right. So that brings us, that was a good segue, Megan, because that brings us to another one of these newer um, exceptions, which I think is great, which basically says if it's part of a value-based arrangement and it's helping coordinate or help them with their care. Now, that doesn't usually involve cash, which makes sense. And it has to be something that the doctor thinks they actually need. We see lots of abuses in the DME world still, where we have task forces and fraud alerts and things about just shipping people things they don't need. So it can't be something like that. But if it is something they need, the value can be way higher than what we talked about with the de minimis. And it's just a lot bigger of a lane just to say, do what's needed for the patient. So we do recommend, it's always a good idea when you're dealing with this kind of stuff, just to have a document, a memo, or some type of thing in the file, just the rationale describing the scope of the program, et cetera. But this allows us to really just in a value-based care world where you're not getting paid for that patient coming in. So it's not the same overutilization worry. It allows us to do what we need for our patients, which is a welcome change.
And especially with the sensitivities around the rising cost of healthcare, engaging patients in this way and going through that analysis, you're taking away that argument that we are truly, you know, increasing the cost of care, because a better managed patient is going to often correlate with a lower cost of care. And so making that investment in the patient and the patient's health is looked at in a different perspective, and is absolutely a welcome change, and opens up a lot of doors both for patients and providers to then partner together to figure out how to overcome some barriers to care.
Right. So there's some other rules we won't go into the details on, but there's waivers that are permitted as part of ACOs, now part of DCEs, or whatever those are called now. But if you're working with an ACO, that's got to go through your ACO board and so on. But again, just another place we're seeing movement. So Megan, thank you so much for joining us today.
Thank you for having me.
And for our listeners, we do have our key takeaways. It's something we like to do. That's available on our website, which our website is
VMDworkingsmarter.com, Wendy.
Okay, the executive producer butting in here. Thank you. And so that's available on our website. Thank you. I also want to just mention that we now have the content available in a couple of different ways. So we do have the closed captioning available on Vimeo. And if you prefer to read the content rather than listen, it's available on a download or a transcript, also available on our website, vmdworkingsmarter.com. So hopefully those options are useful. So last thing I want to just ask our listeners, it's really helpful if you give us a rating, well, a 5-star rating. And if you leave a comment on the Apple podcast app, it's also very helpful to help other people find the podcast. So thank you all for your help. And Megan, always a pleasure. And I hope you'll come back sometime soon.
Looking forward to it.
Thank you to our sponsor, VillageMD. We hope you will join us for future concise compliance conversations.